At this session, we've got apologies from Jonathan Herring and Geeta Nargud, and Jason Kazri is joining us online. As usual, in the interests of transparency, the recording will be recording this, and it will be placed on the website. Everyone, just to remind everybody that we do have external observers online, and to those external observers, you are very welcome. Declarations of interest first, please. Tim.
I'm Tim Child. I'm a part-time consultant to a fertility company.
Jason.
I'm person responsible in a licensed centre. Thank you.
So first, our item on the agenda, as always, are the minutes of the meeting of the May Authority, which was on the 15th of May. Does anybody have any comments or suggested changes on the minutes? You've all had them? No? Can I take them as approved? Thank you. And then we'll move straight to matters arising. But I note that there were only 2 matters arising and they've both been completed. So again, does anybody have any comments on that? Okay, great. So let's go straight to the report of myself and Peter as Chief Executive, where we just sort of give a little rundown of what we've been up to since the last authority meeting. So I, as you will see from the papers, attended at SCAC and also AGC this time. At the moment, I'm attending AGC regularly, subsequent or previous to the appointment of a new member to AGC, which once our new members are appointed. One of the things I did want to just give you a little flavour of is that Peter and I had our annual accountability meeting with the DHSC a couple of weeks ago. We do this every year. Peter basically writes a letter to the department outlining all the things that we've achieved and whether how we've done in, for example, relation to our business plan and so on, and comment on that. And then the department really discusses some of those areas with us and comments on how they feel we've done. It was good to note that it was a very positive meeting. I felt Peter can also comment, but it was very positive. I think the department recognised very much that we've done some good work this year, some important work. We delivered on our business plan commitments. We'd obviously completed all the work of treatment add-ons, which was a very big piece of work taken by SCAC. We've now had several months of OTR, of the register being open, with particularly in February early this year, an enormous uptick in requests and applications for information from donor-conceived individuals about their donors. And we've managed to really deal with those applications. We've got new members of staff. We have reduced our backlog. There's still a lot to do, but we're really on top of this. And I think we should be proud of the fact that it's working well, and also really a big thank you to the team involved, because they've done and are doing an excellent job. I think also the public bodies review, the outcome of the public bodies review was really very favourable. There were a certain number, 15 of small things that we need to do, which we are undertaking. But broadly speaking, it was a very positive review. It was a somewhat lengthy process, and these things are always and never easy, and always very demanding of time. But I think it was the outcome was well worth it, and we came out really well, and the department recognised that. So it was actually a very pleasant meeting, really. And you know, we feel very well supported by the department, but they in turn, I think, feel that we're doing a very good job. So, which is nice to know. The other thing I just wanted to mention is, as you know, that we have started the process to appoint 4 new members. We had hoped that that might be completed by now, the interviews and recommendations have been made, but what with the election coming up and so on, I think that will just be a bit delayed, but we hope that we should have those appointments approved in the coming months. As a result of the, you know, 2 of our members, Gudrun and Jonathan, perhaps having to step down mid-July, and the new members and reappointments of existing members not being finalised, we were in danger of being inquired, and so we asked the department to help us speak to ministers to suggest that Gudrun and Jonathan's term were extended on an exceptional basis for another 6 months to allow the appointment and reappointment process to take its place, to be finalised. We're delighted that ministers have approved that. We thank the department for their support in that, because they were key in helping us get to where we are. And also thank very much Gudrun and Jonathan for agreeing to stay on for up to another 6 months. We're delighted. And so once everything is settled down after the election and so on, we'll be working with the department to make sure the appointments and reappointments are concluded as quickly as possible. I think that's it from me, Peter.
Thank you, Julia. As you've covered the annual accountability meeting, I won't add anything, but clearly if members want to ask any questions, very happy to. I would like to concentrate on 2 things in the list of activities in the paper. The first of which is in early June, Francis Flinter and I participated in an ethics and policy symposium on in vitro gametogenesis. I was always going to get this wrong. IVG, for the sake of my tongue in Leiden, which brought together largely a range of people from across Europe, but also some participants online in America. And I think it emphasised for me something we've seen through SCAC, where for quite some years now, SCAC has been tracking IVG and the progress, but in recent presentations we had, both involving sperm and eggs, what was clear was that work had really gathered pace and was now looking like there was a realistic prospect that it could translate from something that was laboratory based and research into an actual clinical treatment offering. It's unwise, I think, to put timescales on this, but people are talking about things like 5 years or so. And I think that was reinforced in the event that Francis and I took part in. It also reinforced for me a sense that there is work going on in many other countries, and a number of other countries are now starting to actively consider their policy positions on this. So IVG is lawful in research in this country, but is unlawful in treatment. So it is clearly an issue that, as we think about arguments for law reform in the coming years, we will need to take at some point a position on all this. My sense from what was going on, as you can imagine, different countries are in different places. My sense is that the policy debate in Holland and Norway is probably most similar to the position in the UK. And there is certainly a sense, given the long-standing reputation of the UK's regulatory framework in this country, that as with other new developments in past years, there's a sort of sense in which a number of countries are looking to the UK, amongst a few other places, for a bit of a lead on this. I think we'll be obviously at some point engaging with you as a board in much more detail about this, but I did want to put on record that there is work going on across the piece, and as I say, my sense is that there's a proper policy decision to take in the not too distant future. I don't know, Francis, if you wanted to add any gloss on my summary.
I think it's a very good summary, Peter. I guess the only other thing that struck me is that if IVG gametes are shown to work, one of the areas where there seems to be particularly excitement is in their potential use by same-sex couples who could have a child that would be genetically related to both of them.
And the last thing I wanted to comment on, just for information really, before I open up to questions more generally, we have received there's a long-standing group called the Health and Social Care Regulation Forum, and we received an invite to join that this month. It usually meets, I think, quarterly, and it brings together unusually statutory regulatory bodies like ourselves and the CQC, and the professional regulatory bodies like the GMC, the NMC, and so on. And the aim is to, I think, share both sort of policy thinking and also common kind of issues. And as we have found out, of all of us in kind of healthcare regulation, there is obviously a significant overlap between the regulation of professionals and the quality of services provided in a particular healthcare setting. There's nothing I needed to report about this first meeting I attended, but clearly if issues come up which I think merit wider kind of board conversation, I will obviously sort of introduce those as we go along. So that's all I wanted to say at this stage, but very happy to take any questions.
Questions for Peter? Just thank you, Peter. I think it's I think both of those issues that you mentioned will be things that we will need to be thinking about in the future. Firstly, the whole idea of regulating the future, which we're already starting to look at, and we'll hear in that SCAC also is really beginning to think about the real challenges that some of these issues will raise. It's quite telling that when I was appointed just over 3 years ago, somebody, and I can't remember who, said, well, at least this isn't something, stem cell derived gametes aren't something you're going to need to worry about, because it's years before there'll be any. And here we are 3 years later looking at a 5-year time frame, maybe not even. So the speed of change is extraordinary, and we need to, we're mindful of the fact that we need to keep up with that and not be surprised by it. And similarly, the Health and Care Regulators Forum, again, as Peter said, nothing much to speak about at the moment, but it is interesting that it has brought some of the professional bodies into the discussion, which arguably perhaps should have happened before, actually, because I think there's although we have, we might have our different ways of doing things and so on, what binds us, there are quite a lot of similarities and things that we have an interest in common. And I think the fact that we're all talking now is a really good thing. So, okay. So now we come to our committee chair reports. Interestingly, this time we've had a full suite of committee meetings, which is rather unusual, actually. So let's start with Licence Committee, and I'll invite Graham Jones to talk.
Thank you. Our most recent meeting was only last Thursday, so those minutes are not yet approved. But as you'll see, recent meetings of the committee have been dominated by the consequences of serious incidents reported in clinics, leading in one case to the suspension of a clinic's licence. So at our last meeting, last Thursday, Rachel joined us to talk generally about the way in which the executive respond to critical incidents, and that provided us with some helpful insights, I think, more generally about the processes that happen. And it's certainly true that such incidents frequently occasion outside investigations, sponsored obviously by the clinic or the NHS trust concerned. And as we've seen recently, those investigations may lead to some quite significant recommendations about the practices and culture of the clinic more widely, all of which illustrates what we, I think, know, that critical incidents are rarely simply a one-off aberration, but illustrate things which are more serious across the clinic as a whole, and frequently come, of course, through whistleblowers whom the committee as well as the executive are very keen to protect. So I think that's as much as I can probably say about the two recent meetings.
Thank you. We'll take questions at the end, I think. Gudrun, in Jonathan's absence, Deputy Chair, will you talk about SAC, please?
Thank you. There have been 3 meetings since the last authority meeting. The last one was last Monday, and those minutes haven't yet been approved. The other 2 on the 30th of April and 28th of May have all been approved, and there's nothing significant to report.
Tim, on SCAC?
Governance.
Either on this one.
Sorry? No, I think... oh, sorry, on mine it's the other way around. Okay, it doesn't make a difference. So you go.
Yes, so SCAC, we had our last meeting on the 3rd of June, which was fully packed. We discussed emerging technologies and embryo and gamete testing, and in particular PGTP, which is PGT for polygenic disorders, and felt that at the moment this was not something that is useful to predict future health, and it's not permitted in the UK at the moment anyway, but it's something we're watching very closely because it is being used elsewhere in the world. We discussed ectogenesis, which is artificial wombs for early or whole gestation. We discussed androgen supplementation as a treatment add-on, and decided that it did meet the new criteria as an add-on, so we'll be going forward for assessment at a future SCAC. And then we discussed alternative methods to derive embryonic and embryonic-like stem cells also. And then finally, we welcomed 3 newly appointed external advisors, Ying Chong, Peter Ruggun, and Veronique Berman. And then the final thing to say, actually very, very final, is next week at ESHRA, I'm chairing our annual HFEA Horizon Scanning meeting, which is when different experts from around the world who are attending ESHRA are asked to sort of give their views on really what is the future landscape within assisted conception, treatment and research.
Thank you. And Catherine, as Chair of AGC.
Thank you, Chair. AGC met on the 26th of June. All members were present. The main items were the annual report and accounts, including the annual governance statement, with the external audit completion report. We noted that these were incomplete, pending further testing on the accuracy of management's estimates of duplicate cycles arising from PRISM implementation and the likely impact on our income. We concluded that with a number of small amends, we made a provisional recommendation to Peter as the accounting officer to sign. And we confirmed delegated authority to either me or Alex as deputy chair for reconfirming that recommendation to Peter once NAO has finished its work. We plan to lay, once Parliament resumes after the election, 17th or 18th of July and before the summer recess. We had a fulsome report on PRISM and clinic readiness for resumption of Kafka in autumn. Progress has been slower than we'd hoped for a number of reasons which couldn't reasonably have been forecast. We discussed contingencies and the implications for both users of Kafka, clinics and the HFEA itself. We received the internal audit annual opinion, which is moderate as in previous years, which is a good result for an organisation of our size and scope of the audit. But we did also clarify that the direction of travel from the last 2 years to this is progress, with particular strengths noted in strategic risk management, licensing and inspection work, and improvements in relation to data security and protection toolkit. And we were particularly pleased as a committee to note that a substantial assurance on the audit on the Register Research Panel, but a limited assurance on business continuity. And we delved into that in some depth. It was not because of any concerns on the part of the auditors about the existence of a plan and a good plan, but rather the fact that the plan was not yet fully communicated and regularly tested with all staff. But again, we sought assurance and received assurance that those matters will be in place soon. In terms of closure of internal audit recommendations, again, we noted some progress as a result of further negotiation with internal audit about the nature of the risk and the clarification about the appropriate evidence that would be accepted. And we also sought assurance and received it again from the executive that the majority, if not all, of the outstanding internal audit recommendations are on track for clearance. In terms of the strategic risk register, we scrutinised and made some comments on the detail of it and suggestions which I'll expand on later in the agenda. And last but not least, we were very pleased to receive a human resources report showing a very clear staff take-up and appreciation of newly introduced wellbeing days. Very happy to take questions.
Thank you, Catherine. Anybody got any questions for any of the committee chairs? No, well, just to, as always, thank them. Everyone's been really very busy since the last May meeting. So thank you very much for running those committees so efficiently. Yeah, I think we'll have more reports, but SCAT now won't meet, and I think till October. That's right. So we now come to a performance report where everyone has seen it, but we ask Peter and members of the SMT to highlight any key issues. So I'm going to start with Peter.
Thanks very much, Julia. So you can see from the management summary to the report that performance has been good across KPIs this year with this report. In fact, some notable improvements. Some of this is because of the recasting of certain KPIs, and some of it is in response, if you like, to a sort of ongoing conversation we had with you about realistic targets and the like. But what you can certainly see is that there's been a reduction in the number of red indicators. The management commentary provides a bit of an overview of the work we've been doing on key performance indicators. It always was a kind of live document. It's not about sort of shifting the goalposts. It's about measuring things better. And you can see we have a regular process of review, and we've done a review of some of the intelligence performance indicators. And a review of some of the communications performance indicators, which have led, I hope, and if anyone's got any comments, I'd certainly welcome them. I think we've got a bit of better clarity about what it is we're trying to measure and why, and I hope that data feels a bit more meaningful. I usually take the opportunity at this time to say something about the various HR indicators. They're referenced on page 34 of your pack. The position, I'm pleased to report that the position on staff sickness has improved quite a bit. You'll remember that generally our sickness rate is pretty good, but it has been high recently, partly because of winter coughs and colds, and partly because of a number of long-term sick issues. Both of those are being resolved such that the actual numbers now are below target, which is a good thing. Turnover, however, remains higher than we would like. It's currently standing at around about 24%, There are a few sort of percentage points that be discounted from that, but we are still well above the 5 to 15 percentage range that we try and keep turnover. I'm afraid the reasons are the same old reasons as before, that affect a small organisation impacted by public sector pay constraints. So, you know, there are two ways in which you can increase your income in the public sector. You get a pay rise, which is set by Treasury rules, or you get promotion. Pay rises have been pretty limited for a long time, and promotion opportunities in an organisation of our size is necessarily limited. The exit interview information seems to be telling us the consistent story, which is that people like working here, they like their colleagues, they like the issues, but after a while, some of them have nowhere else to go if they want more money. The other thing to set against that is our staff survey results on the whole show a positive picture on morale, with numbers higher than civil service and public sector comparators. And I think generally our HR processes in terms of when we have vacancies, the time it takes us to get adverts out, arrange interviews, secure people and get them in, is coming down and is now as efficient as it's ever been. That's not to, you know, that, if you like, mitigates a little bit to the gap in losing somebody and indeed the extra pressure on the staff that remain. But I won't pretend that turnover, you know, if turnover came down by 10%, that would help enormously. But I don't see any immediate prospect on the horizon for us getting there. But mitigations are working well. So that's all I want to say at this stage. But if anyone's got any questions on any of that, happy to take them before I hand over to Collins.
Peter, can I just say, I mean, it is, it's always really difficult, as you say, with a small organisation within the public sector to stop turnover being high. And I think the two things. Firstly, I think that some of the sort of activities that HR put forward, like for example the wellness days and so on, you know, I think the HR make a huge effort to do everything they can do other than create promotion activities or put salaries up to make to make it, the HFEA, a really nice place to work. And I think you're right, the staff surveys show that people generally are very positive. So I think that is really good. The only thing I would say is, you know, I think it's really hard to reduce turnover under our circumstances, but do we sort of keep in touch with people who've left for, you know, good reasons because they've been promoted or so on, so that because I know we've you know, some of really bright good people have gone off to better things or promoted or higher salaries, but perhaps, you know, there's a way of keeping in touch. So if we do have vacancies at a more senior level in time, we can maybe attract them back.
On the latter, we don't have, if you like, a kind of an alumni register, and perhaps we should. It's undoubtedly true that people have particular friendships with people, say in the policy team or something else. They often keep in touch with people when they've gone. So if you like, we have informal channels of communication that can allow somebody to say, who left, say, 2 years ago, by the way, there's a post coming up in but maybe one of the things we ought to look at is whether or not we could sort of formalize some of that and perhaps get better at that. What I ought to have added is that so for pay purposes, although we are not civil servants in terms of terms and conditions, all HFEA staff are eligible to join the civil service pension scheme, and we track civil service pay as being the benchmark that we work to. Now, normally at this time of the year, the pay award would be known. This time, the government took a decision to postpone the civil service pay award, and instead that timing will now take place nearer the autumn, when the other bits of the public sector pay settlement, be it NHS, police, etc., are known. So we've communicated that to staff. It won't, what I've given staff an assurance of, we'll find out the pay settlement for the coming year late, won't affect when they get the pay settlement, because at whatever point it's approved by REMCOM, the Remuneration Committee, it will be backdated to the usual point in the year. But it's clearly a change of government policy, and I can see a certain logic in doing the public sector at roughly the same time. We'll have to see what the finances suggest in terms of, what's allowable. Last year was the most generous public sector pay settlement for some time, reaching a dizzying sort of 2.5% to 3.5%, depending on circumstances. Whether we match those dizzying levels again, I'm not quite sure. But, the point is, I can't emphasize this enough. If you go back over the last 10 to 15 years, most of these salaries have seen real terms cuts. And in some cases, quite significantly so. So it is a very real issue, and the disparity between public sector pay levels and private sector pay levels at times gets pretty unsustainable. And it is an issue not just for us, but for the wider public sector.
It's a huge issue, and sort of HR activities, wellness days, and so on won't deal with that, but it does help. And I think the continued efforts of the HR department to try to give people other things that make their working life better is really, really important. Alex?
I just thought it was worth saying to that point, we heard at AGC, as Catherine said, the HR report, and we also heard about the further work that's being done to strengthen equality and diversity, which was really great, and also the figures of the diverse workforce in terms of, gender, ethnicity, is obviously kind of, I would say very good, and I know that staff would welcome that equality and diversity work. So I think just further evidence, everyone's doing everything they can apart from the pay point to retain staff.
Thank you. Okay, can I hand over to Rachel now on a range of issues?
Thank you. So I'll pick up on the inspection team to start with.
Rachel.
Thank you. Sorry. So I'll start with the inspections and inspection team, as I'd really like to thank inspectors for their hard work, because you can see the KPIs have really shown an improvement, and that's still with one long-term absence in the team and a relatively new team. We've just recruited again to 2 new inspectors. So thank you for the hard work in doing that, because we've got the KPIs in green now. I think it's just important to note, though, that there are genuine reasons all the time why KPIs might not be in green, and especially when we have challenging and complex inspections where we have to go forward and backwards to the PR or have multiple management review meetings to do the C&E policy, that we can always have genuine reasons for that. But I think we are going in the right direction now that the team are getting more established. With respect to the OTR team, I'm sure you can recall we've got the new case management system in place now that's been fully functional since the spring. We've also got the register tools which help draw out the information from the register. And applications now seem to be around about 80 per month, seems to be stable. We do have the spikes in January when there was the documentary, and we know that there's a new documentary about donation now, so maybe we will have more applications because of that. In May, we closed out 175 applications, and in June, 144. So that's a significant improvement on where we were a few months ago. So we're definitely going in the right way with waiting times for applications now. As mentioned earlier about the DSPT and the audit that was done, we've now done our submission. Again, thank you to Martin, Carl, and especially Alice in Information Governance. They have worked really hard on Neil on this submission. And just to note that although we're making good progress and we're going in the right direction, we get new requirements every year requiring more and more documented evidence, and it's more complex every year. So, and it does take up a tremendous amount of time. So thank you to all of those involved. And then just finally, I mentioned at the last authority that we were planning some pen tests on the infrastructural IT systems. We're now working through those recommendations, and then going forward, our focus is going to be working with procurement, with the department, and thank you for Tom for his involvement on that, of trying to work out the how we're going to replace Epicenter.
Any questions for Rachel? No, so I'll hand over to Claire.
Thanks, Julia. So just a few things from me. Firstly, just going back to committees and licensing. So I chair together with Tom. We take it in turns to chair the executive licensing panel, where the so-called more straightforward items come that don't go to the license committee that Graham chairs. And you can see the changing KPIs from the inspection point of view, but just to say from the ELP point of view, we now see inspection reports coming much quicker after the election to ELP, within a matter of weeks. And we've also noticed recently there is a box where a PR can put a comment in after every inspection, which often isn't filled in, but recently we've noticed a huge uptake in PRs putting comments in there, very complimentary about working with our inspection team, and individually complimenting members of staff, not only from our inspection team, but also if they've had IT problems from the IT side. So I think we've seen a real positive development there. So that's ELP. Another things, Catherine mentioned the very positive audit we have from GIA on the Register Research Panel, which members will remember we came to the authority with last meeting in May. There's been a huge amount of work behind the scenes to improve our processes there, and we were delighted that the auditors recognised how well that work has gone. We have, as you would have seen, gone quite quiet from the communications side because of the election and the restrictions on PERDA until tomorrow. We have got our fertility trends report awaiting publication, which we hope will manage to get out in the next 2 or 3 weeks. Media inquiries haven't slowed down very much, and still a great deal of interest from everything relating to donation, to embryos in storage, to the number of single patients having treatment. So continued use of our data, and particularly of our dashboard. We're planning for the next data reports after fertility trends. The first will be the collection of data for our National Patient Survey, which members will remember we do every 3 years. So that will go out in September. We're hoping for as many responses as possible. And then we'll be publishing also hopefully in September our annual State of the Sector reports that looks at levels of non-compliance and incidents. And towards the end of the calendar year, an update to our family formations report. In other work, we are the work that we were planning, that we came to authority with in May on the statutory instrument on screening. Members will remember this relates to patients going through reciprocal IVF and for HIV positive donors to donate. That screening statutory instrument has been paused because of the election. We hope it might be brought back in the autumn, but we won't know anything further, I guess, for the next few weeks. We'll let you know when we do. I wanted to confirm that members took some decisions at that meeting, policy decisions that were delegated to the chair to sign off, related to any changes to general directions or the code of practice. And I just wanted to confirm that members are still happy for that delegation. Although obviously if the legislation comes through and it's completely different, I will come back to members. And lastly, we are planning for the next few weeks ahead. We assume that whoever wins, if there's a clear win for the election this week, that we will get asked quite a lot of information from ministers within the department via our sponsor team. So whereas we normally try and have a quieter period over the summer to kind of gather our thoughts and plan for the autumn, we expect to be answering quite a lot of communications requests as well as data requests over the next few weeks.
Thank you, Claire. Catherine.
Thank you. I just wanted to follow on, Claire, with a question about the KPI in relation to website sessions. Is there a plan, and is it practical to split that down into the purpose of the website visit. The reason I'm asking is because clearly we know about the proliferation of alternative sources of information, and in particular in relation to the question of selection of fertility services. It strikes me that it might be significant for us to be able to chart, separate from general website sessions, use of the dashboards and or personalized tools.
Check what I say with Anne Harrod, who's head of comms sitting here. I think so. We do collect kind of the top, which are the top pages that are being looked at. So we do have that information. I think that the commentary that says the website activity was broadly stable implies that it hasn't changed very much from one month to the next. But certainly when we launch something new or with the dashboard, we are trying to keep track of that. But it probably doesn't necessarily get into this report. But we can certainly look at the commentary for next time and highlight if I did, if and where anything has changed or something new has happened, what the impact of that has been.
Okay, thank you very much, Claire. Tom, a financial snapshot.
Thank you. So at the end of month 2, we were showing a small surplus, but to be honest, it's a bit too early in the year for that position to be really meaningful or accurate. We're going to do a full review and forecast at Q1. We're doing that at the moment, so we'll have a better idea about how things are looking for the year. And I think we're particularly going to want to focus on staff costs and also the IT investment that we're planning for this year.
Any comments, quick questions for Tom? So now we come to item 6. I'm going to ask Paula to introduce the, sorry, I'm so sorry. We now come to item 6. I'm going to ask Paula to introduce the strategic risk register report. So I think the AGC twice a year gives very detailed consideration to our strategic risk register, which, as you know, is a really important document which highlights the risks that the organisation faces or might face during the year. AGC looks at it in detail twice a year. It's looked at it in detail just at the last minute, at the last meeting, as Catherine mentioned, and now AGC, having been through it, really the authority is now asked to look at it and note it really at this time. So, Paula, do you want to just introduce the subject?
Yeah, sure. Thanks, Julia. Yeah, so apologies if it feels like deja vu to some of you, because it's exactly the same paper that came to AGC. So I'll try and filter in some of what AGC said, and Catherine will most likely like to comment as well afterwards. So I'll just take you through the main points. The financial risk has updated wording to cover the new fee regime and the impact of the grant in aid reduction. The governance risk had only minor wording changes, but we did raise one point at AGC, which was whether there might be a linked risk to be reflected somewhere in the risk register arising from the growth in online services, where we, of course, only regulate bricks and mortar ones. So that's something that SMT will consider when we update the risks again after this meeting. The first information risk has been updated to include an increase lately in media coverage, although, of course, a lot less so during PERDA, as we obviously aren't putting things out ourselves at the moment. There's also the point in there that major work on the website will need to follow on once we've done the epicenter replacement. So in totality, that risk remains above tolerance for the time being. And likewise, so does the second information risk, which we've updated to show the recent changes to the OTR system, which are very positive. But we've also updated the resource risk about OTR from being a future risk to being an open risk. And at AGC, we did acknowledge that things have been going really well with the new OTR system. We're definitely making inroads. So in the real world, it's trending well, but it just felt a bit early yet to change the score. But that's what we expect to do over time to lower the score. The operational risk is also above tolerance, and we've rewritten that one a little bit, including adding in the risk position relating to epicenter. into the management commentary and adding a new sub-risk about Kafka publication, which AGC were pleased to see. And on people, we've reduced the inherent likelihood a little bit to reflect what we feel is our current status. And we've added this point about having a mixture of single points of failure and small teams with low resilience combined with high turnover, which is, all contributes to the risk. On the second people risk, we've also adjusted the risk levels for both the inherent and the residual risks, and we've put them both up to reflect the current position. So that's sitting above tolerance at the moment, pending our long-awaited board appointments. And we reopened the sub-risk about lack of induction time for new members when we get them, as they will have to be probably plunged in at the deep end when we get them. And we did agree at AGC that we would try and make that wording clearer, because it's not that we're suggesting that the induction we give isn't adequate. It's more that if we receive appointments very late in the day, then people, in order to be able to serve on our committees, have to do certain legal training and things like that. So it's about equipping people in time to keep our committees correct rather than the quality of our induction, if you like. And finally, on security, I think AGC just agreed with the strength of the mitigations, but as Catherine mentioned, we've got some elements about business continuity that we'll need to add to that one. And the strategy risk that related to the public bodies review, AGC agreed we could now close. So that one will be closed in the next iteration. So did I miss anything, Catherine?
Thank you, Paula. You captured the vast majority of our points really brilliantly. The only point that I wanted to add, which wasn't really apropos of the strategic risk register, but which is a question for executive colleagues to think about. We have at AGC a regular report on incidents of whistleblowing, which applies specifically to incidents of whistleblowing within the HFEA. But there was an additional question about what intelligence we have from clinic whistleblowing and what use we make of it. And this produced some very interesting information in that inspectors have deliberately been encouraging not whistleblowing per se, but opportunities for whistleblowing direct to the HFEA with any concerns in relation to patient safety or indeed any other matter. And as a result of this, there have been a number of reports from clinic whistleblowers which have caused us to properly investigate and to determine whether or not those allegations should be upheld or not. So the suggestion that we put to the executive was whether or not we needed to capture, depending on the significance of the number of these allegations, whether we needed to capture a new risk in relation to clinic whistleblowing, either in terms of the resource implications, because clearly there's a lot of resource required properly to investigate, or in terms of more general questions about the sources and the consistency of information that we have about sector compliance. So we just left that for the executive to consider and come back to us.
Rachel, do you think the board might find it helpful if you sort of give a sense of how whistleblowing from clinics is sort of encouraged and dealt with within the team?
So we've obviously considered this within the inspection team, because hearing from people on the ground in clinics is obviously gives us useful intelligence anyway when we're doing inspections. So when we are on inspection, it's not just the PR and senior managers that we talk to. I remember having been inspected and having my trainees ask questions stuff. So we make sure that we speak to a range of people and that they can have honest conversations with the inspectors. And what we also do is we have cards that we leave around a clinic that says if you would like to whistleblow or got any concerns, you can contact Sharon as the chief inspector. And we have the result of this over the last couple of years seen an increase in the number of whistleblowing allegations that we receive. I think it's about 25 in the last 2 years. that obviously can give us very useful insights about a clinic and can help inform us for inspection. We do have a very experienced clinical governance team at the HFEA. Paula Nolan, who heads that team up, is incredibly. She's worked at the HFEA a long time. She's worked in a nurse in various areas in hospitals, and we've got senior inspectors also in the clinical governance team with Sharon. And any allegation, like an incident, comes through to the clinical governance team. They then discuss it and decide how to take it forward. There is legislation around whistleblowing that we have to comply with. Sharon has done additional training in the last year regarding whistleblowing, which she found which is found incredibly useful. And then we will talk, Sharon will talk to the whistleblowing directly if they want to. We will look at the allegations. Obviously, our remit, we have to think about our legislation and what we're able to do. A lot of the allegations are HR issues. If we have concerns about that, we can raise with the PR, but we have to be careful about what we actually regulate in a clinic. But there are incidences where these have actually been upheld and have given us useful insight. So we understand that this is it is an important source of information, but it's obviously one of many sources of information that we look for, and especially, on inspection. So we take it seriously, and we're actually encouraged that we do find people that do feel that they can come directly to us as a regulator to share information, and we've seen obviously that increase happen.
It was just one comment for new authority members. For the licence committee, I'm sure we discussed and put it in our feedback that we thought for new members coming to the licence committee that it would be useful when they had the induction that some of the members from the current licence committee were part of that induction process. We thought that might be helpful going forward, because we felt we sat and listened to lots of stuff, but having somebody practically having experience would be helpful, and that might work for other groups as well.
Yeah, I think that's a very good idea. In fact, we were talking about, because one of our concerns with the new board appointments in terms of timing is if you're asking, for example, a new member to join licence committee or SAC, it's quite a long lead time before they feel comfortable in those committees, because they're very, they're complex, and they're, particularly for the lay members, it's getting up to speed with stuff that's really unfamiliar to them. So it does take a few months even before somebody's really, sort of really stuck in and very useful on those committees, which means that so for my concern was in terms of getting board appointments done in a good time, but parallel to that, the idea that we make the induction as useful as possible. It's a very good induction, actually, on the whole, but I do think you're right. Having existing members being part of that is definitely something to consider. Anybody got anything else for Catherine or Paula, or anything on the risk register? Otherwise, are we all happy to note it, Peter?
Thanks, Julie. I wonder if I could just update the board on risk, what we describe as the people to risk. So that's page 60 in your pack, which currently is above tolerance. So there's two elements to this. And since this risk was written, effectively, one element has fallen away. So the two elements were that we were concerned that delays on decisions, ministerial decisions on board appointments, would mean that the board as a whole was inquorate. In other words, if Jonathan and Gudrun simply terms of office had ended in the middle of this month, you would have found yourself with a board that did not meet the requirements of the Act. Now that a decision has been taken to extend Jonathan and Gudrun, that element of the risk falls away. We are, however, still left with the second element of the risk, which is that with decisions on 4 new members to come, gets back to Julia's point about induction. As you all know, the issue for us is not simply getting board members on in time, is getting board members in sufficient time that they can go through an induction process that they can then sit on the various statutory decision-making committees. So that element of the risk is still real until we get that. And one of the problems with us having board appointments really up to the wire is that we could be then asking them to participate in committees very, very quickly after taking office. And given that many people are pretty busy anyway, they may well have quite a busy committee diary already, which doesn't match with the committee. So that risk has moved on a bit, if you like, since then. So one element is resolved, the other is still open. But as Julia said, hopefully the 6-month window we've got now will allow those appointments to come through with sufficient speed that new members can be inducted in such a way that we can still deliver the various sort of formal licensing business in a smooth and robust manner.
Yeah, thank you, Peter. I hope so. And be assured that although we've got the very welcome extensions of Gudrun and Jonathan, our feet is not off the pedal. We'll just wait and think until whatever government it is in place next week, and then we can start pushing again to make sure these appointments are made in a timely way. Yeah. Okay, so this leads me to all the items are important, but this is a particularly important item, which is the fees review. I think it's been alluded to earlier that we've had our grant in aid, our GIA, which comes from the sort of government, has been reduced, which leads us as an organisation rather more vulnerable to collecting fee income or to income generation generally. And we think, as we've discussed beforehand, that we should be doing a fees review, potentially looking at increasing our fees to help minimise the loss of the GIA, and also generally it's probably time we did this and look at what activities we should charge for, because since I think the last time the fees were looked at, there have been new activities such as egg freezing and so on, which are new. The sector has increased the activities it carries out, but the fee regime has sort of not kept up with it, I would say. Clearly, any fee increase has to be approved firstly by Treasury, and secondly probably we will need to go out for public consultation on that. So this is quite a long piece of work, hopefully concluded somewhere in 24-25, and this is really the start of it. So what we thought would be useful today would be, and you've seen some of this in the papers, to look at the various options that might be available if we were to increase fees, as to how we would do it. Now, I'm to be really clear, this is not taking any decisions today about how we're going to increase fees or what we think, what we want to do. What it is, I think, is to give Peter and Tom a sort of steer, a direction of travel about what we think might be reasonable in terms of the options for fees, and give them some sense of how we're feeling and have a bit of debate about it. They will then go away and do some more work, and then gradually over the next few months you'll see this coming back to the authority until finally, hopefully, we'll have something that we can firstly put to the Treasury, because there's absolutely no point in us agreeing a new regime if Treasury don't like it. So we will get their steer on it pretty early on, and then also go to consultation, and then hopefully eventually agree something for implementation next year, probably even as far ahead as 26, 27. But that's sort of where I think where we want to be. So this really just kicks it off. And Tom, why don't you introduce the paper and what the options might be?
So we've been considering this review for a while now, and I think the broad range of options open to us is fairly well understood. we could move to something that's more of a fixed fee for clinics annually, or we could stick with something that's quite variable, or we could move to something that's a mixture of variable and fixed. We could focus more on charging against regulatory activities, which probably moves us a bit more to something that feels kind of more explicitly like a full cost recovery approach. Or we can stick with focusing on clinic activity, which I think more kind of reflects how busy a clinic is and you know, a bit more towards its ability to pay. I mean, ultimately, we set our budget every year as tightly as we can to make sure that we have enough money to deliver our statutory duties. And the fee mechanism is really just a way of apportioning our costs as fairly and sensibly as we can across the clinics that we regulate. I think there's a couple of things that are really important in kind of deciding what options we want to choose. I think the first one is kind of the principles that we want to use in doing the review. Kind of, you know, what is it that we want to achieve, and what do we want the final kind of revised mechanism to kind of feel like. The second is really, I think, understanding the impact on HFEA and on clinics from a funding flow perspective. I mean, we need to make sure that we can cover our costs, and clinics will want to have some certainty and consistency in kind of understanding what the fees are going to be for them each year, as well as, you know, wanting to know that they're as fair as they can be. I think any change in a fee mechanism like this is always going to end up in a situation where some clinics will end up paying more and some clinics will end up paying less than they had done previously. And I think we need to do some work and analysis to kind of understand what different options might mean from a clinic and from a HFEA perspective.
So would it be helpful? Well, I don't think we've got this on the slide, have we? But if we go to page 74, which are the options. I mean, the general principle, I think, in any fee review is that the regulator is expected to recover the cost of regulation from the sector it regulates. And I think, as I alluded to before, you know, we are a sector that's where the activities has expanded very, very quickly and will continue to expand, actually. So we need to have an eye on the future as well. And obviously the fee regime has not really kept up with that. So there are new activities which are not regulated. Tom, would it be helpful if you just took us through very briefly the five options and just gave us a sort of feeling of where you are on this, so that we could sort of think about it and maybe discuss each of the options you know, when you've done that? I think it would be really helpful.
Yes, of course. I mean, these are really kind of broad types of options, and I think, you know, we can explore looking at mixtures of those options. The first one, to stick with what we're doing at the moment, I think, you know, we're looking at the moment at a fee regime that's based very much on clinic activity, and I think we feel that because activity has changed over a number of years within clinics, the choice of activity that we've got in that option at the moment is probably not as equitable as it was. But that said, we could still kind of stick with a clinic activity based fee regime if we wanted to, and kind of tweak it a little bit. The second one is kind of reviewing that a little bit more and changing the balance a little bit, potentially between the amount of clinic activity that we use versus the amount of regulatory activity, and you know, potentially charging a little bit more for inspections and things like that, and charging a little bit less for clinic activity, but kind of trying to maintain some balance in that way. The third one is very much, in my mind, focusing purely on regulatory activity, and that's thinking purely from a full cost recovery perspective, which I think from our case, it would be extremely transparent, a way of showing that fees are covering our costs, but it could have quite a big impact on clinics, because it'd be quite a movement away from the way we charge clinics at the moment, where, you know, a clinic that has a small amount of activity will pay considerably less than a clinic that has a large amount of activity. But if we do it from a regulatory perspective, it could be broadly the same. The last two are kind of around a fixed flat fee, which is, I think, in a way, us calculating using an understanding of our internal costs, what kind of an average regulatory cost might be for an organisation, and trying to kind of have that fixed. So we remove some of the variability and provide a little bit more consistency and predictability for clinics and for ourselves, and set an average fee. The final option is kind of taking that approach, so having a fixed and a more predictable approach, but potentially grading it, looking at the approach we have at the moment and recognizing that some clinics are more active than others, potentially meaning that, you know, it's an average, but if you're a very active clinic, you might be in a higher banding than in a less active clinic.
Tim.
Thanks. It's really good summary, actually, of the different options there. I mean, I'd have thought from a clinic point of view, obviously, well, first of all, obviously there's a major shift towards more cycles in which the stimulation IVF cycles in which the plan is not to do a fresh embryo transfer, which is leading to all of this. So, you know, there's much more, whether it's elective egg freezing, or whether it's elective embryo freezing, or whether it's PGTA, in which case there's a month or two's delay between the egg collection and then the embryo transfer. So there's a huge shift in activity worldwide, and so it's quite right that we can't just do nothing. I think doing nothing's not an option. But two initial thoughts would be there is wide acceptance, as you say, by clinics of how things work at the moment. So it wouldn't be much of a shift to tweak it from the point of payment is an egg collection, because all of the big change is egg collection cycles not reaching embryo transfer. Well, if the trigger point is doing the egg collection, you then capture all of the egg freezing, PGTA, absolutely everything for almost minimal change. And I can't see anyone in the sector pushing back on that, because that's fine. I suppose you could then split it into two, and, you know, the total cost at the moment for an IVF cycle with a fresh embryo transfer, because there is a shift towards more delayed frozen embryo transfers, you potentially could split it into 2/3, 1/3. You know, 2/3 of the cost is at the point of the trigger for the egg collection, but then you're also potentially charging for frozen cycles, because that is where the growth is. And then the other option, I think, the banded flat annual fee, which is a bit like, I guess, the council tax thing, although obviously the rates are very out of date with that now. But that sort of thing, I think a flat fee across all clinics, probably you would get pushback from the smaller clinics in the sector on that. But I think some sort of banding, I think there would be acceptance. And very interestingly, I think that would then bring in a disconnection between the fee and a per cycle fee, because obviously the other options per cycle, those costs are instantly pushed towards the patient. If it's a banding fee, it would be very difficult for a clinic to do that. It would be absorbed, obviously, so the patients would still be paying for it in some way in a private clinic, but it wouldn't be a per cycle basis. It'd be quite difficult to do that. And just to say on the banding, I would expect to use, if we did go down that route, I'd expect to use clinic activity as a way of determining which band they should be in anyway, so we could get kind of a basket that would be a bit more, but would still be recognisable to clinics.
Thank you. I'm sure there are many things to consider, including what is workable and practical. I just wondered, from the HFEA's point of view, is there a big difference in those 5 different options in terms of how much work it involves at this end, just bearing in mind that this is a fairly small organisation with a slim staff? Does that factor that comes into it?
Yes, it does. I suppose at the moment we've got systems set up to count IVF cycles, and it's kind of fairly well automated, but we're kind of counting 65,000 times 100 for IVF, which is, it's a lot of counting, and there's risk of error, and you know, we're going through some discussion with the NA at the moment around duplicate invoicing. So reducing error and having something simpler would reduce the amount of work for us, I think. it would make things a little bit easier. And certainly we wouldn't want to move to a fee regime where we're kind of changing the things that we're counting or looking for different bits of information apart from what we're already collecting.
Can I just ask one more quick question? Moving down a couple of pages, one of the things that's listed for which there's a fee, and I'm sorry, this is just my ignorance, third-party agreement with centres not licensed by the HFEA. Can you just give me an example of what sort of thing that is?
So that could be a satellite clinic. So you can have a centre that is fully licensed by the HFEA, regulated, inspected, but it may be that you have a regional smaller hospital, for example, that has a fertility clinic there, such as that just does the workup and does consent, and then the PR has a third-party agreement with that centre, so they do the workup of the patient, and then the patient goes to the primary centre for egg collection, embryo transfer.
And I think it's really important. That's a really important thing you raised, actually, Francis, because I think our feeling is that those clinics are, or those satellite type organisations or online organisations are going to grow, and that's because they probably weren't that when the fee regime was first brought in. They probably weren't that significant, but I think they will become significant.
Thank you. First, clearly this is going to be an iterative piece of work, but as a preliminary paper to the authority, I find this incredibly helpful and well set out in terms of the principles to influence the shaping of the decision, but also an outline of the options. Of the 5 options presented, the only one which I would say to me stands out strongly as incompatible with the principles set out is actually the regulatory activity only, for a couple of reasons. Clearly, for the reason that Tim outlined, in terms of clinic activity, the market is changing so fast that it would be difficult to see how a regulatory activity model only could deliver on the principle of fairness and transparency. But I also think that to me, it seems very unlikely to be able to deliver the budgetary certainty and the financial planning certainty for us as the regulator, or indeed for clinics, particularly as we see more and more shift in terms of the market, in terms of number of entrants and ongoing clinics, as opposed to those which are fusing by dint of M&A, etc. So I have an instinctive sense that probably won't be a model that an option that we need to consider long term. But more generally, I just wanted to put forward a couple of points. Firstly, on the principles, as I say, I do think that the principles that you've captured are absolutely good and right and essential to keep at the forefront of thinking. But I wonder also whether we might want to add a principle that we do often consider in terms of in terms of inspection when we think about possibilities of changing an inspection process, and that is securing even earlier compliance and even more consistent compliance across the sector, i.e. incentivizing somehow in a financial method, as well as perhaps in terms of the earned autonomy, which is often discussed in other regulated markets, that earliest compliance. So we might want to think of that as a principle. And in terms of options, the only option which isn't currently set out, and I know has been considered in other regulated sectors when reviewing fee models, is an option which takes into consideration what I might call the additional cost of regulated activity, either because of non-cooperation or repeated non-compliance. So I just wonder whether that isn't something that we might want to factor in. I see all sorts of practical reasons that it would be very difficult, but I think that we ought properly to consider it. And the third comment that I wanted to make for future iterations of this issue for discussion at authority is that I think it would be very helpful to have comparators in terms of principles and options that have been considered either by other healthcare regulators or by other regulated markets in terms of factors that we ought to make sure that we have considered properly and not discounted too early.
Thank you, Catherine. Jason and then Graham.
Thank you. As a knee-jerk reaction from somebody working in the sector, my immediate preference was status quo plus. Okay, so it has advantages in terms of already being accepted, and although there are still some gripes over the system, I think that will help enormously in maintaining good feeling within the sector. But I think there are also some advantages to it in terms of the way that clinics work and also potentially the way the HFEA works. So in terms of the way clinics work, as a clinic, that's going to allow you to, your payments will adjust as your activity adjusts. So it's a very adaptive system. And I wonder whether there are some advantages to the HFEA also in that, because as regulated activity increases, income to the HFEA increases. And so you won't be caught out by having, say, a huge increase in activity in whatever it may be, in vitro derived gametes use, for example, which then isn't covered in payments because you're using a sort of flat or banded fee structure. I do take on board Tim's comment though around the sort of banded flat annual fee also having some advantages in terms of decoupling that association that we've had with some centres potentially in the past, linking the HFEA fee as almost making it look like a HFEA treatment tax, for example. However, if we were to have a banded flat annual fee, my question would be how often would that be reviewed? Because obviously centres will change in size, etc. And so for me, status quo is an absolute no. I don't think we can maintain the status quo. Regulatory activity only, I think that for the same reasons as colleagues, I don't think that would particularly work. And a flat annual fee, I think, as we've said already, would disadvantage smaller clinics potentially. So my thoughts would be B or E, and B would, I think, be the easier to apply in so many ways. That doesn't necessarily make it the right thing, though.
Graham.
Yeah, I'd reflect much of what Jason has just said. I agree it's a very good paper, and as I read it, I was thinking, well, if we were starting at the very beginning, then the banded flat annual fee would seem the simplest way of organising receiving the income from the clinics. But the crucial sentence that I read was clinics itemise the HFEA fee on bills to patients even though we do not charge patients, and the whole culture of those fees are collected seems to me to be an important one in relation to this. So you'd be going on to an annual fee, you would be changing a culture, and I think that's one of the reasons I'm sure Jason thinks that B would be the most likely one to go forward. And what I've not got is any great sense of what the sort of scale of an annual fee might be. And it would be useful when we get the final paper to have some sense of what is it a clinic would be charged, what proportion of their income. It's probably relatively small in proportion to the overall income, but what would it be? Because that would be quite a substantial sum to absorb if it wasn't anywhere in their own charging structure. And that seems to me a practical issue, but it is also part of the very culture. If we'd started this way, then 30 or more years ago with a fee to clinics, it would be much easier. I think it's quite difficult to imagine shifting to that, given the itemised way in which our fees are charged.
Thanks. Could I preface what I'm about to say by saying I'm not necessarily advocating this approach, but in the spirit of the way Julia asked us to embrace the decision today, the concern whenever we talk about fees and putting fees up, as Graham and others have said, is this is going to get passed on to the patient, and we could put it up by 5% and the clinic will put the price up to the patient by 5.2% or whatever that might be. And so all these options, and I agree that it's a good paper, are based on a predication that the fees will be some kind of percentage on top line income for the clinic. There will be a top line income based on, we might add egg freezing or whatever cycles, etc. They get some money and we take a percentage of that. So the point I'm trying to make is, with variation of fees, and whilst we're not an economic regulator, is there not something we should throw into the model where fees are predicated on a percentage of top line income, but also a percentage of bottom line income, which might therefore stop inflationary rises in what the public are paying to satisfy the HFEA?
Should think about that, Alex. You need to look at our powers, but I get exactly what you're driving at. I don't have much of a more coherent thing than that, but I don't think that's worth dismissing. I think that is worth thinking about. To take Graham's point, I mean, you're sort of right, but, and the but is this, isn't it? In the end, the fees that clinics charge reflects their total costs plus whatever profit they're seeking to make. And in respect of things like heat and light and the other sort of things that are necessary to run a business, those things just get the difference is that patient doesn't see, cost of blood test, etc., your proportion of the electricity bill or something. That's just part of the corporate cost of the organisation. But make no mistake, they are recovering those as part of their fees. So the virtue, if you like, of a bandit of something like it, is that it makes the cost of regulation, if you like, more like, as Tim suggested, the varying running costs of a business, rather than something you can directly identify in the bill that patients get at the end of the day. But regardless, a fee will, a clinic will be recovering the total costs of its organisation, but it does break that link. You're right that a shift from an activity-driven model to some kind of flat fee is a big culture shift, and that shift alone might make it a harder argument to win. But it's not like the one, in a way, one of the difficulties of the activity model is a couple-fold, really. As people have said before, is we currently levy a charge on used to reflect the bulk of activities in the sector. They no longer do in the way that they did. So there's a mismatch already, which takes you from option A to option B. And it is, of course, certainly from our perspective, an unpredictable number in that clinic activity could just drop by 10% or chargeable activity. Our regulatory activity has stayed the same and our regulatory costs have stayed the same. We've got 10% less income. That's not great. Clearly, the virtue of something like E is that it's pretty predictable. You're absolutely right, though. I think until you can see what those numbers might be, in the abstract, you can kind of understand the argument, but is that a bill of what? But clearly, I mean, if with an annual fee, what we want to do is say to a clinic, so you're a clinic of a certain level of activity, your annual fee will be X. We will issue, 12 monthly invoices to spread the payment out, and probably at the end of the year we'd make a next year prediction on the basis of historic activity levels or something, and sort of hold the fee for each year going forward, I imagine, rather than it moving endlessly. So, but I take your point. What I'm hearing from you all is the next stage of the discussion does need some sort of meat on the bones, in which we move from sort of theoretical models to actual numbers, so you can see what these, what an annual fee might even look like. And the other thing to say, of course, as Tom said, is this is not a business in the sense of we are merely trying to recover the costs of our regulatory activity. And in fact, so the ideal outcome is we come in at zero in the sense of costs we register equal 95% of our activity and they're net off. This is not a, one of the things we'll have to say when we go out to talk to clinics about this. This is not designed for us to generate more income. This is designed for us to generate enough income to cover the costs of regulation.
And then I've seen Gudrun and say.
I'm sorry, I'm still trying to work out the percentage of the top line. What were you alluding to, Alex?
That there might be an option that fees, as well as take fees coming from the money that clinics bring in, fees might come from some relation to the profit they're making as well.
I just wonder how you're going to find out what the top line of clinics are. That might be a bit of a challenge in itself. And I have to remember there is still some NHS in the mix as well. But I think if we're starting from the very beginning, I think we would start with a regulatory activity model. But I think that horse is long gone from the stable. The activities were absolutely right. And I think as Jason alluded to, and Tim, B and E are the probably two preferred options, but E needs quite a lot of work done. It sounds a bit like the electricity and gas bills that will vary each year, depending on your usage to a certain extent, and that the banding would need to be quite well looked at. Having lived through these before, I can't think, the last one was probably about 8 years ago since we looked at fees, 6 years ago.
Model hasn't changed
Models.
very long.
It hasn't changed, but
Number might have changed.
we've looked at it because we looked at banding before, and then it was up to then centres to think, well, if I do 500 cycles, 500 egg recoveries, I'm in this band, but if I do 501, I'm in that band, because we have been through this thought processes before. So that's why I'm just saying that we need to really work out quite carefully what the banding would be based on what the activities are. So as I think we've said, B and E are the two key things which the sector can work with. But that's certainly one of the things that we discussed at great length in centres, that if you did, as I say, 500, you were in band D, but if you did 501, you were in band E, and if you did 1,000, you were in band F, and if you did 1,001, you were in band whatever. So it's just that kind of activity level, just for you to think about.
Richard.
I think there should be a basic fee, a bit like telephones, and then there should be a fee for activity, and there should be discount for good clinics.
Okay. Zeynep. Well, Zeynep and Alex. Yeah. And Zeynep and then Alex.
Yeah, I think this is a really interesting discussion. Part of me feels that even though practically speaking, I can understand the reasoning, we should put aside the consideration about how we've been doing it so far and just look to see what the ideal or best possible way going forwards is. And it seems that there is a variety of different issues here. One of them being making sure that the activities that are covered are commensurate with the activities that are taking place. So not leaving out things like freezing activity, for example. One of them is an issue of efficiency and predictability and fairness. And I think also the symbolic, the symbolic message given by how this fee is applied is also really important. So I've mentioned in this committee before, and we've just discussed it. I think it would be, for me, it's a huge plus if the way we enact this going forward can be done in such a way that it cannot be passed directly on to patients on their bill. I think that's a symbolic change that has the potential to change a patient's relationship with the HFEA, because at the moment, for most patients, one of the first or most important things they know about the HFEA is that they're paid, that they pay a fee for the treatment that they receive. So I think that's really important. I think E has the potential, if it's thought through well, which I'm sure it can be done, to be quite seamless, so that with certain numbers clinics move up and down, and so clinics know full well you know, what they're going to be paying each year, because they know their projected activities, they know the activities that they've done, and it's really important, obviously, to put in all that freezing activity in there as well. And I just feel that, you know, that would look much better from what we're looking at. And in terms of the kind of the percentage costs, at the moment it was 85. We had a discussion about potentially raising it to 100. I mean, in terms of the cost of an IVF cycle, that is absolutely minuscule. So in terms of the overall profits of private clinics, I would assume that, you know, it's going to be, it really is just a very, very, very small drop in the ocean. And in a way, having that banded might also show what good value clinics are getting from the HFEA, that, you know, the HFEA fee they pay is, you know, probably going to be like 1/10 of their electricity bill, or 20th, or whatever it is. So E would be my preference for sure.
Thank you. Alison, and then Jason.
So it was just a comment really about in the reports, there was 3 centres that owed HFE 190k for over a year. So there must be something right about compliance for non-payment of bills. I mean, you wouldn't owe anybody else that amount of money without having some interest at it, or some sort of compliance round about it. So it's a little bit following on from Gudrun's idea of, if you're good, you get a sweetie, but if you're bad, at the moment, you don't get anything at all. And obviously that's something that we should look at, because to be 190k out of your annual income is really it's not acceptable.
Jason.
I think that's a very good point that Alison makes there, and we've talked, haven't we, about fining clinics that don't comply as well, and that's potentially in the works. But I just wanted to make a few comments around, again, B and E, and the difficulties with both. It strikes me that there are difficulties in how you define activity, both with B and E. So when you're banding, for example, on E, what do you include in the banding calculation? Because it could become an incredibly complicated calculation to make if you're trying to broaden out effectively what you are making chargeable to centres. I think E becomes fairer if you have a lot of bands, but at the same time probably becomes more difficult to manage. And I do wonder, I'm sure we've asked this question before, I do wonder if there is a way that we can influence the way that the current system is presented to patients. So if we were to go with B, for example, is there anything that we can do to prevent clinics from presenting this fee as a treatment tax from the HFEA?
Thank you. Anybody, because then I'll try and wrap it all up. Anybody got anything else? Tim.
So I have to respond to Alex a bit there. I think you chucked that one out there, but I think from a fee structure based on, you know, either revenue or profit, I mean, it basically, I can't see how it could work. I mean, obviously the NHS side has been mixed into it. Interestingly, the most recent heavy activity from the HFEA has been to do with NHS clinics rather than private clinics, in fact. So I think it would be very difficult, though. I mean, even if you try to narrow down and think, okay, well, how much profit could an NHS clinic be making? The costs within an NHS clinic are impossible to work out, because they don't pay real costs for heating or space or anything at all. So I get the idea, but I think it would be just unworkable. In fact, I do like the idea, as I mentioned earlier on, the costs from the bill, and as has just been said, you know, E would get that. And I remember there have been discussions beforehand, as Alison said, and there's all sorts of issues. If you're a new clinic starting up, okay, well, how much does a new clinic pay? If a new clinic is taking space in a business park, then you'll probably get 2 years free rates. They don't pay rates for 2 years. Is that what we're going to do? I mean, you need some way of keeping the costs down for new clinics starting up as well. But I do like the idea of decoupling it from the patient. Of course, in the end, the costs are going to be passed on to the patient. You're not going to get any company just absorbing a 4% increase in costs without passing it on. And it's going to be unreasonable for them to do that. Of course, they're going to do that, but it might not be itemized on the bill.
Rich.
just wanted to mention about initial applications because they are extremely time consuming for our inspectors because we're looking at absolutely everything, every bit of paperwork, patient information, SAP going into clinics. And very often there's a very much to and fro between the clinic and inspectors. The inspectors really do support a lot of work, help, advise. It's more involved than a regular renewal inspection, and sometimes we do all that work and the clinic doesn't go on to finish the application and open, and we're not recouping those costs at all.
Yeah, can I add?
Yeah.
And just to build on that, I think whatever model we end up on, we will want to have a look at initial applications. Because, I mean, I take it with a new business needs to build up customers and the like of it. But, my understanding is to often a successful IVF business at the moment is going to require significant upfront investment. And the regulatory barrier to entry at the moment doesn't remotely reflect the cost of actually helping clinics get to the point where they are in a position to offer good, safe treatment that complies with the UK framework. So I think almost regardless of any option we choose, we're going to have to do something about that sort of barrier to entry, because we are spending an awful lot of money, which we're not recovering.
Anyone else? Okay, so I'm going to try, Tom, and give you a bit of a steer. So I think, mindful of a good point, that we should, when you're doing this exercise, not exactly reinvent the wheel and start again, but start as if what's the best possible outcome, even if we then have to pull back from it and compromise because it's never a particularly, nothing's ever perfect. It feels as if B and E were the ones to look at. That's not a decision, but that people felt that perhaps B and E needed looking at a little more closely. And I think there are a few things to take into account in that. Firstly, I think, regardless of whether we go for banding or activity-based fees, although bandings seem to be a bit more favoured, we do need to take into account changes in activity and what sort of activity needs regulating and the cost of regulating that, bearing in mind we have to recoup the cost of regulation. And that activity should include, as Peter just said now, initial applications. We should also look at perhaps, what action could we take where clinics are constantly non-compliant, and that costs us a lot. We spend, the license committee themselves know this, we spend hours and hours, as does the exec, on non-compliant clinics. Tom?
Sorry, just to say on kind of non-compliance, I suppose the more regulatory cost activity focused approach kind of naturally does that a little bit, because if you're not complying and you need additional inspections, we can potentially charge for the additional inspections. So even though it feels a bit clunky, those benefits potentially.
I'm just saying these are things, we may already be thinking of, and some of them we are already thinking. I'm not saying we aren't doing them, but these are the sorts of, so it's changes in activity, additional activity we might not have thought of, and so forth. That needs to be taken into account. That's the first thing. Second is burden on patients. I think everyone's very clear that, this, whatever the additional cost is, it will clearly be passed on to patients. But if it could be passed on in a way that doesn't highlight this, as Jason calls it, a treatment tax, and that the patient experience is not that it looks at the bill, that he or she looks at the bill and the first thing they see is an HFEA tax. So there's that. I think you made a very good point that whatever we do, we need to consider resource constraints internally, because agreeing to a system which puts a sort of intolerable burden on the internal workings of the HFEA sort of rather defeats the issue. However, I'm slightly sort of reluctant to say that, because I think we need to look at the best, the best outcome possible, and then try to manage the resource around it. But I think it would be foolish to disregard it altogether. And you made a very good point. So I think B and E, I'm hearing it are the ones that require, we think probably merit a bit more, a bit of a closer look. And these are the 3 or 4 things I've just outlined that perhaps you need to really take into account. And it was a very good paper, and you probably are already taking it into account. But these are the things that the authority will be looking for when they're being asked to approve the next iteration of this. Does that feel to you like a sensible way forward?
Yes, thank you. That's really, really helpful.
Okay, thanks everybody very much for that. Is everybody content then to let Tom and the team go forward and come back to us when they're ready with sort of Mark 2? Yeah. Okay, great. Okay. So we are nicely ahead of time. It was not a particularly long agenda. I've got a couple of any other businesses. Before I do, just to say that as Claire mentioned, the team, I think everybody will be quite busy over the summer post-election. And we're already having some internal discussions about what the next 6 months might look like, because if there were to be any changes in government, or that might affect us, we, as you know, are about to approve the strategic plan 25-28, but we might need to go back and rethink and revisit, depending on what the outcome of the election and any areas within that of government policy that might affect us. So I'm just putting that as a marker of something we need to do. September, and in particular the away day in November, where hopefully we will have new members then, will be really important. So please put that into your diaries. I also just wanted to mention, because some of you have asked, that, as you know, we are sort of partnering, or at least we're collaborating with Girton College on the conference on the 30th of October to celebrate the year of the 100th birthday of Mary Warnock. That is, I think, within this month, registration will go out for that. We've got a great programme, and I think it will be a very nice event. Just to say that when you I'll write to everybody and say, this is the link for registering, but don't leave it too long, because if you'd like to come, only because there's been quite a bit of interest so far. So it'd be really good to make sure you get places. My final bit of any other business is just to say happy birthday to Ali, who's spending a very happy birthday being our wonderful school secretary. Anybody else have any other business? Okay, so everyone have a really good summer. I hope it's not too busy, and look forward to being really very busy when we return in September. Thank you.